I'm Dr. Shataj Khan from Peshawar, Pakistan. I'm not a cardiologist by profession. I am a hematologist by profession, and I'm a professor of hematology. I've been treating thalassemia patients, and the most common death that I comes across in controlled thalassemics is sudden cardiac deaths and cardiac complications and heart failure. So that led me to an idea that I should present something to the cardiologist that these patients that we are treating regularly, unfortunately, the disease is chronic morbidity, mortality. I wanted to put up these complications to the cardiologist so that they can help around with our treatments. So my objective is to introduce hematology, the thalassemia major and other thalassemic disorders. What is the incidence around the world? What is the pathophysiology of how the heart is affected and the clinical features when there are cardiac complications, along with the diagnostic work that needs to be done, and then how to manage this. Thalassemia is one of the most commonly inherited blood disorders worldwide, not just in Pakistan. In Pakistan, we see around 5 to 7% of the population having this gene known as thalassemia trait. And when two traits marry, there is 25% chances of producing a thalassemia major patient. So you can very well imagine the amount of burden and how many newborn babies come up with a thalassemia major. There are two types of thalassemias, the alpha and the beta. Alpha is not that complicated because they are not transfusion dependent, but beta thalassemia patients, there is a variety of it. One is the transfusion dependent beta thalassemia, and a minor amount is non-transfusion beta thalassemia major. But both of them have cardiac complications, and both of them, even despite of the fact that non-thalassemia dependent patients, non-transfusion dependent thalassemias, although they don't take blood, but still that they are cardiac problems because of iron overload, mainly because of the increased absorption of iron because of the anemia, and because of the hemolytic process that is going on, and the oxidized iron is being absorbed and deposited into different parts, different organs of the body. So the spectrum of thalassemia syndromes ranges from severe transfusion dependent and asymptomatic carrier state. As I said, in Pakistan, we have 5 to 7% of our population having the carrier state. And the intermediate is a milder form, and usually non-transfusion dependent. They become transfusion dependent in case of a hemolytic crisis or in females in pregnancies, etc. Whenever there is some other chronic disorders, then they become transfusion dependent. Otherwise, they need no transfusion at all. We have a study that show more than half of the cases in a center in Rahim Yar Khan had cardiac complication back in 2015 when proper chelation was not being given. So there was a big burden of cardiac complications in these thalassemia patients. Another study carried out at Aga Khan showed the high prevalence of severe myocardial iron overload in these patients as well. What is the pathophysiology? Number one is the iron overload complications, which includes reversible myocyte failure, arrhythmias, and arterial changes. In the non-iron overload complication includes pulmonary hypertension and thrombotic episodes, thrombotic strokes, which is a much more complicated cardiac complication. Here I would like to tell you that in complications which is common to both thalassemia dependent, transfusion dependent, and non-transfusion dependent thalassemia includes extramedullary hematopoiesis. The liver and the spleen takes over the hematopoiesis, so they have hepatosplenomegaly. Then there are ulcerations because of the thrombotic changes. There's growth retardation, skeletal abnormalities, renal abnormalities, iron overload complications like jaundice. The transfusion dependent thalassemia seems to be better, but they have more complications than the transfusion dependent thalassemia, and that includes ineffective erythropoiesis, thrombosis, pulmonary hypertension, heart failures, gallstones, infections, and hepatocellular carcinomas because of the repeated transfusion causing iron overload in these patients, and the repeated transfusion have more chances of developing hepatitis C, most commonly because there's no vaccination towards hepatitis C. We have been able to control hepatitis B because we are regularly transfusing, the transfused patients are being vaccinated for Hep B. Then there is folic acid deficiencies and acute hemolytic episodes. So cardiomyopathy involved are dilated phenotypes. These are with left ventricular dilatation and impaired contractility. The viral myocarditis, because viral infections like Hep C is more common in these patients as compared to the normal population. Then there is a restrictive phenotype with restrictive right ventricular filling, pulmonary hypertension, and right heart failure due to iron overload. And due to repetitive transfusion, viral myocarditis is a common feature in the patients from a younger age. So this is the pathophysiology. There's repeated blood transfusions leading to iron overload, leading to parenchymal tissue iron deposition, leading to iron transfer capacity increase, leading to non-transferrin bound free iron appearing in the blood, and then that generates a toxic oxygen free radicals. These free radicals are stored in the lysosomes and released when intracytosolic buffering mechanism fails, leading to oxidative damages, cell death, and fibrosis of cardiac tissues and vessel walls. This decreases lysosomal fragility as well. The oxidative damage, cell death, and fibrosis of cardiac tissue further leads to loss of ventricular compliance, decreased mitochondrial inner membrane respiratory enzyme activity, decrease in antioxidant enzyme activity, and a smaller overshoot and action potential, and electrophysiological heterogeneity leading to arrhythmias and cardiac complications. So this is the main pathophysiology of the arrhythmias in restrictive myocarditis secondary to iron overload. And this is very common after at least at the age of 10, when the patient is being regularly transfused, and we have to really take care of the cardiac point of the patient from the cardiac point of view. So the earlier stages of cardiomyopathy is supraventricular ectopic beats and no sustained tachycardia. In the later stages, there are malignant arrhythmias leading to atrial fibrillation, atrial flutter, intraatrial reentrant tachycardia, and are common in these arrhythmias. The ventricular arrhythmias are more specific for iron toxicity because of the toxic radicals being released and the lysosomal failure to take these toxic radicals. We have seen sudden cardiac deaths. Many a times the patient is lying asleep at home, and the parents report that he didn't awake in the morning, and that is because of sudden cardiac deaths. And complete heart blocks are common too in these thalassemia patients before receiving chelation therapy. Even after receiving chelation therapy, there is still chances of cardiac complications because of the non-responsiveness at times due to lack of medications, poverty. So these cardiac complications are common in these patients. The clinical features, the symptoms includes shortness of breath or difficulty in breathing, sometimes even at rest, as is common to all the cardiac failure complications. There is palpitations, fainting, chest pains, feeling very tired, and unexplained swelling around the ankles due to cardiac failure. Again, this is a diagrammatic presentation showing transfusion-dependent thalassemics and non-transfusion dependent thalassemics. In transfusion-dependent thalassemic, we see cardiac cirrhosis, which is very common, and that leads to arrhythmias in heart failure, along with all other complications of the body. In non-transfusion dependent thalassemics, there is more chance of pulmonary hypertension and silent strokes. This is again because of the lack of oxygen supply to the vital tissues of the brain and of the lungs. Now I'll go through the diagnostic workup for cardiology point of view. A thorough medical history, as I said, there is a similar history like in any cardiac failure, that is shortness of breath, easy fatigability, and chest pains. So the gold standard for screening is a 12-lead resting ECG, which is being properly read by the cardiologist and the ECG consultants. A detailed echocardiogram to show the activity of the heart, and T2 star MRI, the cardiac magnetic resonances are very important because this is the most important point to see the magnetic relaxation property of cardiac tissue, which is inversely related to intracellular iron stores. So we differentiate here between the idiopathic cardiomyopathy and patients with iron overload cardiomyopathy. In cardiac iron overload cardiomyopathy, the transthoracic echocardiography with full diastolic function assessment and mitral and annular tissue velocities are to be seen regularly. Abnormal left ventricular diastolic function or decreased peak systolic tissue velocity, if it is present, even if it is present in idiopathic cardiomyopathy, we go for T2 star MRI. If the T2 star MRI is less than 10 milliseconds, what we do is we divide this into three portions. That is T2 star MRI less than 10 milliseconds, T2 star MRI 10 to 20, and more than 20 milliseconds. For those having less than 10 milliseconds, we have to go for repeat echoes and cardiac MRI in 6 months' time and evaluate for therapeutic response. We start with oral and intravenous and subcutaneous iron chelation therapy, and we have to monitor it every 6 months. Those having T2 star 10 to 20 milliseconds, we continue the current therapy, and we monitor the myocardial activity in 1 to 2 years with echocardiography and T2 star MRIs. With those more than 20 milliseconds, the patients at risk of intra-iron overload cardiomyopathy continues current therapy for the iron overload cardiomyopathy is taken care of and monitored. Those that do not have abnormal left ventricular diastolic function, we repeat transthoracic echocardiography every 1 to 2 years. So a preliminary report done on eligible thalassemia major patient presenting with these problem April 2014 and for a year between April 2014 and April 2015 showed that most of the patient had cardiac overload in these major patients. A total of 83 patients with thalassemia major, age 5 to 45 at presentation, 42 star were reviewed. The conclusion was that there was a high prevalence of severe myocardial iron overload in these patients, and that serum ferritin did not correlate with T2 star. That was the very important finding because it is the serum ferritin that is usually done regularly, and this MRI, T2 star MRI, is present only in very specialized centers. So most of our patients do not have the capability of reaching these places easily. A key driver-based quality initiative by doctor in our society, Dr. Shabneez and colleagues in 2020 was implemented to improve chelation for accurate estimation of iron overload and cirrhosis by T2 star MRI in 2 centers in Karachi and Pakistan. And the result showed that 100 patients with TTD median age 17 years were affected. This study also showed that increase in T2 CMR was documented in 82% of the patients in post-intervention phase, especially in patients with severe myocardial iron overload. And the conclusion of this study was this initiative improved the chelation therapy, leading to improved cardiac status in transfusion-dependent thalassemia patients at participating centers. So the management is regular iron chelation, both oral, intravenous, and with the in subcutaneous infusion, and that is being regulated mostly by the hematologist through the ferritin level, but as I said that this did not correlated with T2 star MRI, so these should be done regularly in the patient suffering from thalmajor on transfusion or non-transfusion. Optimal doses monitoring is very important, and for heart failure, continuous 24-hour desferoxamine infusion has shown to improve the cardiac function. In our setups, we give infusion 5 to 8 hours a day, 5 days a week, but that will only reduce the iron overload from other organs. Whenever there is heart involvement, this is to be given over 24 hours for several days and monitored regularly. Again, a triple therapy of deferriprone and combination with deferasirox and desferoxamine as pressor medications. This also improved the conditions and morbidity as well as the mortality. So EPIC study, which is evaluation of patients' iron chelation trail, showed normalization of T2 star in over 68% of patients and mild moderate baseline myocardial cirrhosis. In severe baseline myocardial cirrhosis, there was an improvement of T2 star level 10 to less than 20 milliseconds after 3 years of regular therapy. This is another Hyperion study, phase 2 trial, which demonstrated a 9% improvement in T2 star at 12 months with combination of deferasirox and deferriprone with deferasirox monotherapy. A 30% improvement in cardiac T2 star was noted in 24 months of the treatment. Again, deferasirox 30 to 40 milligram per kg per day significantly includes cardiac burden after 12, 18, and 24 months of treatment in chronically transfused beta thal patients. That is a Novartis study, US 04 study. So it means that all these patients, after 20 transfusions, we have to monitor the ferritin. We have to regularly give them deferasirox 30 to 40 milligram to keep the ferritin less than 1,000 and between 500 and 1,000 in transfusion-dependent thalassemia patients and less than 500 in non-transfusion-dependent thalassemia patients because they have more chances of developing pulmonary hypertensions, and that leads to sudden deaths as well. So the main point of my presentation was to improve the cardiac functions in thalassemia patients. We have to regularly give chelation therapy, and those not on chelation therapy will have sudden deterioration in health and increase in morbidity as well as mortality. With that, I end my presentation. I know it would have been a bit too much for the cardiologist, but I wanted the cardiologist to see that we as a hematologist, we are burdened with cardiac complications of health major patients. So if anybody has any queries or questions, I'm there. Thank you very much for your patience.